Here we are, chapter 26, Medicine. This is a huge chapter in the book. It's like cleaning up all the little bits and pieces of everything that didn't quite fit into another chapter, so they dumped it all into this chapter. So for chapter 26, I promised you that there would be a little announcement that you could see on the schedule that I said we usually break it into 3 groups because it is so large. So for chapter 26 only, the way I want you to do your homework is I want you this time to do the learning objectives. There's a lot of them, but it really is the meat and bones of this section. For the theory questions, only do number 3, number 9, and number 14. For the practical section, I want you to be in 3 groups. So the first group, if your last name begins with A through D, as in David, or dog, there's 7 of you, and you will do questions in the practical section 15, 16, 17, and 24. Group 2 is if your last name begins with an E and ends with an M, you will do questions 18, 19, and 20, and 24. And group 3, your last name begins with a P as in Peter, ends with V. You will do questions 21, 22, 23, and 24. So you notice that every group does number 24. That is our story problem, if you want to say it. That is where you're going to read the op report, and I want everybody to have that experience of doing that ophthalmology clinic progress report. I will type this out and put this in an announcement also so you can see it in black and white. But I just promised you that in this video I would let you know who was doing what section for homework. So it's quite a bit less homework, but that's because there's so much reading in this chapter, and by doing your learning objectives I think it will really help solidify it all. Okay, so here we go on our slides. I'm going to buzz through some of these. So a lot of this stuff is all things that we've seen before, so there isn't any reason to dwell on them. The subsections have very specialized tests, audiology, biofeedback. A big part of this section is on immunizations. This is the most often used code in this section. There's 2 types of immunizations, active and passive. Your correct coding has to include the supply that was injected and the administration. So be sure that you're doing both of those. Quite a few of you missed the supply in the last chapter's homework when we coded the diaphragm. A few of you got it. I'm really proud of you. But remember, you don't want to supply or give anything away in your practice. You have to make sure that you're keeping track of all of that. Active bacteria or virus, the bacteria that causes the disease made non-toxic, is injected to build an immunity. So you think about allergy shots. A small dose active virus injected is a vaccine, and that's, for example, to build immunity. So that would be like your polio. A passive immunization does not cause an immune response. It contains antibiotics against certain diseases. The immune globulins identify the product. For example, if this is a botulism antitoxin, you want to and again, you always want to report that administration separately. So your immune globulins codes are divided by type, method, and dose. So a rabies shot can be intramuscular and it can be a full dose, or it could be a hepatitis B shot subcutaneously and multi-doses. So you need to remember those 3 things when you're coding the immune globulins. The immunization administration for both of those is reported with the substance giving, but you need to pay attention to those immunization codes, okay? So for patients through the age of 18, a lot of you want to work in pediatric practices, you're going to use 90460 and 61. For a patient that's 19 years of age or older, 90471 through 74. Patients of all ages, including those under 19, if the physician does not counsel regarding the immunization. So, if you have a pediatric patient who's coming in for a well-child checkup, you're going to code that well-child checkup, and your immunizations are going to use your 60 and 61 codes, and they're going to be in addition. So you need to make sure that you're coding those correctly, okay? So be careful when you're doing combination immunizations. For example, a DPT. This is all combined in one injection. Even though there's 3 immunizations that you need to document, you're only going to give one administration code. Okay, all of you MA students, your stars for as far as this goes, your percutaneous, is it intradermal, subcutaneous, or intramuscular, and it's intranasal or oral. So you need to make sure what kind of administration you are coding. Report administration code for each dose, and again, here are some examples. Your toxoids, there's many codes for age or dose specific. So if you're giving a polio vaccine for a single disease, or a combination of diseases, DPT as we talked about, or the flu vaccine, is it a split virus and you're doing it twice? Toxoids, there's some examples here for your hepatitis A, for example, and you want to make sure that you're paying attention to those. Okay, don't assign a modifier 51 with a vaccine toxoid code. Rather, depending on the payer, it could be listed multiple times or using your times symbol. So those are important reporting rules that have to do with those vaccines. So they can be administered during an office visit and not be related to the E&M code, in which case you would put a 25 modifier on it. If the office visit is for the vaccine only, code only the vaccine and no E&M code. Routine vaccinations, most of the times flu vaccines are given in a flu clinic, or now everybody's getting them at the pharmacy. So you don't need to worry about coding those unless you're working for the pharmacy. Psychiatry section, the treatment is at the same time as an E&M service. Report one code for the therapy with your E&M code. Time is your major billing factor for all of these psychiatry codes. The codes are all divided according to time, and the medical record will indicate how much time was spent, a start and a stop time. So and your documentation always has to support it. Many services are provided in partial hospital settings. The patient can be in the hospital during the day, return home at night. Or we can have interactive psychotherapy for children. We're using play equipment, physical aids, art, music, those kinds of things. Biofeedback. We talk about gaining control over your body processes, high blood pressure, chronic pain, those kinds of things. Medicare doesn't pay for that, for biofeedback, especially for psychosomatic disorders. So you need to read carefully. Patient has to be trained in biofeedback by the professional and then continues on their own. So sometimes those services are included there. Again, you need to read carefully. Dialysis is in this section, even though it doesn't seem like it should be, but this is where it is. So we have dialysis cleansing the blood, either temporary or permanently. So temporary is non-ESRD, non-end stage renal disease, or permanent is end-stage renal disease. 2 parts to report this dialysis service, the physician service and the hospital side. Hemodialysis is the procedure used for both of them, billed per day for inpatients receiving this care. It includes all the physician E&M services, so you're going to use that 25 modifier if there is a separate identifiable E&M service provided. Miscellaneous diagnosis procedures, just make sure to look at those. The peritoneal dialysis, in which the toxins are passively absorbed into the dialysis fluids. The patient will only see, the doctor will only see the patient during the dialysis session. How would that code? Well, you want to make sure that you're appending that 25 modifier to your E&M code. Peritoneal dialysis, we kind of talked about this a little bit when we were on that section, on the renal section. So there's just the very same picture that we had before. Dialysis training, patients can receive training in self-dialysis, and you would code for that. Gastroenterology, so this section is for tests and treatments of the esophagus, stomach, and intestine. So you're going, my gosh, we had so many codes already in that section. Well, here we are having some more. So these are several intubation codes are in this section, and so you need to pay attention to those. Ophthalmology in this section contains E&M codes. And no E&M codes are from the front of CPT. These are all a very specialized section. So the definitions for new and established patient are the same. Most codes are for bilateral, but if only one eye, you're going to do 52 modifier, reduced service. Read the definitions of intermediate and comprehensive services to make sure that you know the difference. Okay. Ophthalmology, For example, an intermediate one with the physician would review the history, external examination, ophthalmology scope, biomicroscopy for acute complicated conditions, not required. And so then those are intermediate, and then comprehensive ones have even more medical decision making, which cannot be separated from the techniques that were being used. Special uh, otorhinolaryngologic services. These are for special evaluations of the audiologic system. They go beyond those usually provided in an evaluation, and they may be reported in addition to the basic audiologic service. So there are some more special ones that you can read about. And all hearing tests are bilateral unless there's only one ear. Again, this is the same kind of thing that we want to make sure that you're using that modifier 52 for. There's coronary therapeutic and services and procedures, so your PTCA, all of these things we talked about in cardiology, so just scan through all of those. And there's your cardiac cath code again, and we've talked about all of that before. We do have some non-invasive vascular diagnostic studies that would come into this, but review those all in your chapter 17 where we already talked about them. Pulmonary, there's some ventilation codes, as I said, some management codes are in this section. Allergy and clinical immunology, these codes are all in here, and so you could look through those if you're doing an allergy testing or ingestion challenge. A sensitivity testing, the type and number of tests are based on the physician's judgment, so you're only going to code those which he tells you. The medical record will tell you the number of tests, the type of test, and the method of testing. So sensitivity to food, drugs, and other substances, the initial 120-minute testing time, and then there's another code for each additional 60 minutes. Services that are less than 60 minutes, you're going to just use an E&M code. So again, time is so very important. The codes are developed into 3 types of system of services: injection, prescription and injection, or provision antigen, the substance only. If you have a nurse in the family, it's going to give the shots at home. Physician services are bundled into immunotherapy services. If there's a separate E&M code, you're going to report that separately with a modifier 25. For example, if you're getting an allergy shot and you have a severe reaction and the physician now has to come in and perform a separate E&M code, give you a nebulizer treatment, you're going to code that. We're going to see if he's going to give you another injection of a suspirin or something to stop that reaction. So you need to read your notes very, very carefully. Neurology and neuromuscular procedures. This is where all your sleep testing, your neurostimulator, your brain mapping, all of these tests are in this section. Central nervous system assessment and tests. All of these, again, when you think of a testing, you think of this section because this is where all these things got bundled. Okay, and they're usually based on a per hour basis, with the exception of developmental testing. But every one of them has a written report. You have to have a written report or you can't code it. Hydration. So we have an infusion. We have for example, a new OB patient who has severe nausea and vomiting. She presents for her regular OB, but she's so dehydrated, we either give her the infusion there or send her over to the hospital. So you need to make sure that you're reading all of that, what fluid it would be. You want to make sure that you're coding anything that you're giving a patient. So any supply, that 99070 code, you need to make sure you're using that, or HCPCS codes if your payer requires it. So here's more hydration. There's only one initial service per encounter. If the patient presents for hydration and it has drug therapy, for example, your chemo patients, then that would be subsequent, okay? So make sure that you're looking at your time, your hydration for 1 hour. Your second one is for hydration hour 2 and 3, and then if there's a push, okay? Therapeutic, prophylactic, and diagnostic injections and infusions. This includes all of your chemo, and so you need to make sure that you're paying attention to those. Less than 15 minutes is a push, okay? Chemotherapy administration, so there's lots of codes here. The chemical can be injected many places. You need to make sure that you're paying attention to which one. And again, as always, if you have an E&M code, it's going to have a modifier 25 on it. Chemotherapy administration. So these IV drugs, there's 2 methods of delivery. The IV push, 15 minutes or less, or the IV infusion is over a longer period of time. You need to also pay attention if the provider needs to be there during this infusion, its prolonged services. Okay? And if there's multiple drugs given by different routes, a separate fee will be paid for each route of administration. Chemical agents are reported separately. Those are your supplies, and any special supplies, special needles, anything else that you need to do. You need to find those drugs in your HCPCS book, and they're all J codes, and they're all generic. And then if there's any kind of a cut down, an interarterial catheter placement, you need to make sure that you're coding that. That coverage has restrictions for Medicare. So, for example, patients who have liver cancer and colon cancer that is metastatic to the liver, you need to make sure that you're finding out which diagnosis is applicable. These injections with chemotherapy are reported separately from any analgesic or any medicine for vomiting. It can be administered before or after therapy, and again, report both the administration and the J code. Photodynamic therapy uses, in addition to bronchoscope or gastrointestinal codes, the injected agent remains in the cancerous cells longer than normal cells, so it absorbs the light. So this photosensitizing agent produces oxygen and the cancer cells are destroyed. Special dermatologic procedures, these are highly specialized. A separate E&M consultation code may be appropriate. And so here are some of the procedures that we're doing with people who have special skin conditions that need ultraviolet light or light-sensitive chemicals or light rays. Physical medicine and rehabilitation, traction, electrical stimulation, therapeutic exercise. The patient has special training. You need to code whatever treatment and patient training is happening. These codes often have time components, and they are divided according to physical or occupational treatment therapy. Modalities are divided on supervised, on constant attendance. Active wound care management. We have a whole section of ELKS that's called wound care management. This is what they do. So they remove the necrotic tissue, either with or without anesthesia. They apply pressure. They do all kinds of procedures. So codes are used with, not to replace, a surgical debridement. We talked about that much earlier when we were talking about intergumentary. This is different than that. So you need to pay attention to where it's happening and what's happening. So you need to document every part of it, the size, the character of the wound, the direct one-on-one patient care, and the treatment plan and patient education. Osteopathic and chiropractic services are in this section, both in and outpatient, and physician services are bundled into these codes. The codes are divided on the number of body systems affected. Then here we have our telephone and online services. We've kind of talked about that before, where we have non-face-to-face, non-physician services, handling and conveyances, follow-up post-op, office visits or after-office visits, Medicare bundles most of those special services. Our very last slide is talking about the supplies and material, 99070. By now you've got this ingrained just indelibly there that you can use that all the time. Okay? And so if you have any questions about this, let me know. Ask Teresa or email or discussion board or whatever you want to do, and I will type up an announcement that lists all of those assignments again. Okay, good luck everybody. Hi everybody, here we are, chapter 27. I know that you're as excited as I am. So this chapter is the last one in our textbook, pages 705 to 730. Inpatient coding we've touched on as we've gone through the semester, talking about various and other sundry things. So this kind of puts it all together and puts a bow on it. According to the announcement I sent out to you, I have also posted the answer key to this section. So relax and just go through the section, go through the video, knowing that you are going to have the answers to your homework in the end. You're going to do reverse coding. You're going to have the correct answers, look them up, and give me the page numbers. And so this is just going to kind of put a bow on this whole section. I'm briefly going to go through the PowerPoint. It's not very long, so here we go. Selection of inpatient principal diagnosis. So principal diagnosis in the office is called the chief complaint, but in the hospital, in inpatient, it's a principal diagnosis. We talked about that when we talked about E&M coding. This is the condition that is established after the studies, after the tests are all done. It's the chiefly responsible condition for the patient's admission. This applies to all non-patient settings, acute care, short-term, long-term, psychiatric hospitals, home health care agencies, rehab nursing homes, etc. The coder should list any additional codes that may describe any coexisting conditions that affect the care of the patient for the encounter. When you're selecting that inpatient principal procedure, you're going to use a different book than we use. So our ICD-10 book is CM, Clinical Management. This one is principal diagnosis from the hospital. So the principal procedure. It's definitive treatment rather than diagnostic or exploratory. It's necessary to take care of a complication. If two procedures meet the criteria, you report the one most closely related to the principal diagnosis. The procedure is significant if it's surgical in nature, carries a procedural risk, carries an anesthetic risk, requires specialized training. The diagnosis and procedure must correlate. The medical necessity must be established through documentation. No correlation, no reimbursement. So remember we talked up the very first, when we're talking about E&M coding, about the MSDRGs, the Medical Severity Diagnosis Related Group. Those are the drivers for insurance companies. It has to be, your diagnoses have to fit and your procedures have to correlate, and they have to fit within this MSDRG. So we talked about that a lot. Remember, reimbursement is different for a hospital because they provide broader services. You do things in the hospital you would not do in the clinic. So we have section 2A, signs, symptoms, and ill-defined conditions. Inpatient coders do not need to code a definitive diagnosis until it has been established. So they can do not code when definitive diagnosis has been established. So if you're doing, if you talk about a patient coming into the hospital, has a severe cough, we do a chest x-ray, we see they have pneumonia, you're not going to code that symptom or that sign, you're going to code that pneumonia. So, and this is true for outpatient as well. If you do that, exercise 27.1, it will really help solidify these ideas and give you some great examples. Section 2B, when there's two or more interrelated conditions. So two or more interrelated conditions exist. Either can be the principal diagnosis, either can be sequenced first, unless it's indicated otherwise by the circumstances of the admission, the therapy provided, the tabular list of the alphabetical, for example, mitral valve stenosis and coronary artery disease. They're two interrelated. They're both cardiac diseases. Either can be the principal diagnosis, either can be sequenced first, MSV versus CAD. Resource intensiveness affects your choice. So if the mitral valve stenosis is presumed to be of rheumatic origin by ICD-10-CM, which is what we use in the clinic, right? So, but you want to see which one you're going to do. So if you have a patient who has a mitral valve stenosis and you're doing an echocardiogram, you would code that one first because you're looking at the stenosis, not the cardiovascular disease. So if you're doing a cath, you're going to look at the coronary artery disease first. So that's why you would code that one first. So look at what your resources are, what you're using, okay? Because that's going to make the difference. To section C, there's two or more equal diagnoses. Either can be sequenced first. So a diagnosis of viral gastroenteritis or dehydration, or if they're both being treated. If only the dehydration is being treated with like IV fluids, and the gastroenteritis is being treated with oral medications, sequence the dehydration first. So that's another good example. Section D talks about comparative or contrasting conditions. So these could be either or. So the code is confirmed in the inpatient setting. If determination cannot be made, either can be sequenced first. So the patient comes in with what seems like pneumonia, but it could be lung cancer, lifelong smoker, had it in the past. There's some reason for that. It's a rare occurrence that this would ever happen, but if they're both being treated aggressively, then either one of them can be coded first. So do the symptom, and then section E talks about symptoms followed by contrasting comparative diagnosis. So symptom code sequenced first. If a symptom code is integral to the conditions listed, then and no code for the symptom is reported, then use the other diagnosis. For example, a patient is admitted for chest pain. It can be either gastric reflux or peptic ulcer disease. So first of all, you're going to code the chest pain. Then you're going to do the gastric reflux or the PUD, the ulcer disease. The rule is code first the underlying condition causing the symptom. If it is also necessary to code the symptom to explain resources, then do that. But that's a rare example. If it happens, the physician would state the diagnosis as symptoms due to X or Y. So this is different from the previous section when the physician said the diagnosis as X or Y instead of using the symptoms. This is a symptom he's talking about this time. The original treatment plan was not carried out. So you had a principal diagnosis, and then it becomes a condition that after study, the reason for the admission as the inpatient and the treatment does not have to be carried out for the condition. So you need to, again, read all of your notes and make sure that you're understanding what is happening to the patient. So the condition that occasioned the admission to the hospital could be sequenced as the principal diagnosis, even though the treatment may not have been carried out that way. So here's an example. A patient was admitted for elective surgery, then developed pneumonia, so the surgery is canceled. The code for the reason for the surgery first is coded. Remember, we talked about that when we talked about surgeries. The code surgical or other procedure not carried out because of contraindication. So that would be the pneumonia, C53.09. And then you must also code that pneumonia. You want to paint that whole picture. You want to make sure that we understand. Another example, a patient comes in for an elective tonsillectomy due to chronic tonsillitis. But when the patient gets there, he's found to have a very high fever. So, which would be coded first, the chronic tonsillitis or the fever? Well, according to this rule, the reason for the surgery is the tonsillitis. So we're going to code that first, and then we would code the fever. Okay? Hope that makes sense. Okay, section G, complications of a surgery and other medical care. If an admission is for treatment of a complication from a surgery or other medical care, then we want to sequence that complication code as the principal diagnosis. If the complication is classified in the T80 through T88 series, the code lacks a specificity to describe the complication, or an additional code for the specific complication should be assigned. Okay? If you have an uncertain diagnosis, this is section H. If the diagnosis at the time of discharge still states probable, suspected, likely, questionable, possible, or ruled out, or probable, then code the condition as if the condition existed until it's proven otherwise. Inpatient facilities can do this. Physicians report a definitive diagnosis or signs or symptoms. So the workup, the observation of the therapies would be the same whether one is treating a confirmed condition or ruling the condition out in this case. An uncertain diagnosis continued, so we have a cough and a fever, probably pneumonia. If the patient's inpatient, code the pneumonia, do not code the cough and the fever. And then, as we learned in outpatient setting, in our CM settings, we code the symptoms, the cough and the fever, and we don't code it at the pneumonia until it's been confirmed. So that's one of the differences. Inpatient coders can bill for probable possible diagnosis, but outpatient coders, as we are, cannot. Okay? Section H, continue this uncertain diagnosis. There's two exceptions. The first is AIDS. When we studied AIDS in the chapter B, B20 should only be assigned for confirmed cases. And the other one is the avian flu. So J09X2 should only be assigned for confirmed cases. We don't want to start a pandemic without having the correct information. Section 2I, admission from the observation unit. So if the patient is admitted for observation for medical condition which worsens or does not improve, then the patient is usually admitted to that same hospital for the same condition, and the principal diagnosis is the medical condition which led to that admission. If the patient is admitted to observation to monitor a condition or a complication following an outpatient surgery, they thought the patient would be able to go home, but they started spiking with fever. So then they're going to admit them. Or is the patient subsequently admitted as an inpatient to the same facility, and the principal diagnosis then is that condition established after study to be chiefly responsible for the admission. So again, if the patient has complications after an outpatient surgery, is admitted, that is exactly what you're going to code for the reason for the admission. This is based on the Uniform Hospital Discharge Data Set as a definition of a principal diagnosis. 6J, we're continuing with our admission from outpatient surgery. So for example, a patient receives surgery in the outpatient surgery department. He's then subsequently admitted for continuing inpatient care. Then you need to follow those same guidelines for finding your correct diagnosis. If it's due to a complication, assign the complication. If there's no complication or medical condition that can be documented as the reason for the admission, assign the reason for the outpatient surgery. If admission is for another condition unrelated to the surgery, then you're going to code that as your principal diagnoses. Reporting additional diagnoses. So we can have additional diagnoses are defined as those additional conditions that affect patient care. They can require clinical evaluation, therapeutic treatments, diagnostic procedures, the extended length of a hospital stay, or increased nursing and or monitoring. So something unrelated to the primary diagnosis, and now we're having other complications. Reporting additional diagnosis continue the guidelines when neither the alphabetical index or the tabular list provide direction. The diagnosis reported in the discharge summary should be coded. That's why most coding doesn't happen until the patient is going home and you have that discharge summary, which is also why if you're working in a medical office, you want to make sure that your physicians are getting their discharge summaries done and back to the hospital. You can have resolved conditions or status post procedures from the previous admissions that do not have bearing on the current stay. In this case, don't code those. If they don't bear any bearing on what's going on now, don't worry about coding those. History codes only if they impact the current care or influence the current treatment. Abnormal findings of X-ray, lab, pathologic, or other diagnostic tests are not reported unless the provider indicates their clinical significance. If the findings are outside the normal range and the provider has ordered additional tests to evaluate, query your provider. Ask him, should these abnormal findings be reported? Is he going to be doing further testing? If a diagnosis as documented at the time of discharge is listed as any of those lovely, probable, suspected, likely, questionable, etc., you want to make sure that you're basing it on the diagnostic workup and that you're correlating those to the treatments. Okay, ICD-10 PCS replaced Volume 3 procedures of ICD-9 CM. They made it more specific. There were 4 objectives to guide this development. It was the completeness, expandability, multi-axle, and standardized terminology. So if a character doesn't apply to a specific procedure, use the letter Z. That's where we got so many of those codes. It's because of ICD-10. So if the tabular list provides remaining characters needed to complete the code given in the index, be sure that you're doing it completely. Okay, that's the end. Chapter 27. Yay, we're finished. Now your homework is reverse coding. After you completed your homework, as I listed in the announcement, I will send you an email letting you know whether or not you are exempt from your final. Okay? Good luck, everybody.